Hello, and welcome to today's webinar on artificial intelligence in medicine. My name is Dr. Jesse Ehrenfeld, and I am the immediate past president of the American Medical Association, and coming to you today from beautiful Milwaukee, Wisconsin in the United States. I'm board certified in both anesthesiology and clinical informatics, and I'm a senior associate dean at the Medical College of Wisconsin. I'm also the chair of the AMA's delegation to the World Medical Association and a member of the World Medical Association's Technology Working Group. Joining me today in hosting our program and the series is Dr. Jacob Mathew, an emergency physician and a digital health innovator coming to us today from Doha. There are so many questions that physicians all across the globe have today about the explosion of AI tools in medicine. When should I be using these tools? How should I be using them? Are they safe to use? Are they ethical to use? Is it ethical to not use these tools? What is generative AI? How do large language models work in medicine? Are these things going to replace me as a physician? How will my role change with the adoption of these tools? So with all of these questions on the minds of so many, the World Medical Association is absolutely delighted to offer to our members a series of 5 webinars on artificial intelligence in medicine, covering various aspects of the use of AI, the opportunities and the challenges that they present for physicians all across the globe. So today, we're going to cover the basics with an introduction to AI in medicine. On February 27th, we'll cover ethics, legal and regulatory aspects. On March 27th, we'll talk about current and future applications of AI in medicine. On April 30th, we'll get into best practices in the development of these technologies. And then on May 22nd, we'll close out with a conversation about global health and equity and the implications. We hope that you find this series useful and that you'll be able to tune in for other segments in this exciting series. And so now I am so pleased to turn the floor over to my dear friend and colleague, the president of the World Medical Association, Dr. Ashok Philip.
Thank you, Jesse. It's very kind of you, the introduction, and I think a very enthusiastic preview of what we are going to be seeing over the next 5 months. As Jesse said, this is such a new field that all of us sort of freeze when we hear AI. I used AI for this, I used AI for that, and we think, oh, this guy knows a lot, and I know nothing. So we want to make sure that everyone knows something at least. And there's no better people to do this than those people who are really into clinical informatics and who use AI, perhaps not every day, but very regularly. I know that I'm one of those people who's going to be learning a lot because aside from what comes in the newspapers and occasionally in legal opinions and about liability, I know very little indeed. In fact, I think next to nothing about AI. So both Jesse and Jacob have great experience and great expertise in the field. And I now will leave them to enlighten us all. And then after that, we will have a question and answer session with them. Over to you.
Thank you so much, Dr. Philip, for all that you do on behalf of the World Medical Association. We're so excited to dive right in. So, Jacob, when you think about what's going on in digital health, there's an explosion. Right. So, I see so many of my colleagues, talking about these tools, wanting to use these tools. What are you seeing in your practice and in your travels in terms of what the adoption curve has been?
Thanks so much for the question, Jesse. And, I think across the board, ever since we can really call it a watershed moment with ChatGPT, it's come into everyone's vernacular of using AI. And what we're seeing on different levels is that people are using it to format their notes. They're using it to help with their clinical decision support. And now we're seeing companies integrating these AI tools on a certain level. So it's been at a broad adoption, and now we're seeing it being deployed in specific use cases. How about yourself? What has your experience been?
Well, there's good survey data out there. 93% of physicians think that these digital health tools are helpful, have some advantage, are worthwhile. And the average physician is using almost 4 digital tools. That's double from just a few years back. And certainly in general, I think with what happened with COVID-19, the pandemic, the rapid adoption of telemedicine, there's been this sort of huge influx of an appetite and a comfort in trying to transform our workflows using these new and exciting tools. The question is, what does this mean for our daily practice? What does it mean for our patients? And what's the impact on healthcare delivery? And I'm curious, what are you seeing these tools doing today at a clinical level in terms of the impact on the delivery system?
I think, like we're talking about, we're in the early stages of widespread broad adoption. We're seeing specific smaller use cases, especially in specialities. So I think we're beginning to see it in administrative roles, admin sort of aspects. And then in terms of specialities, we're seeing the adoption in terms of radiology, dermatology, ophthalmology. And these are, I think we're going to talk a bit more about why that is in the next session. But, playing into the computer vision aspects of it. So as we see these kind of aspects, and I know like countries are doing some sort of fast pathways to adopt. Countries are allowing them so that we can adopt some of these tools in a rapid way. But it's not, I don't think there is going to be a single specialty that is not going to be impacted in some case or the other. What do you think, Jesse? I mean, do you see that, in your role as an anesthesiologist, is it coming down? Have you been employing it?
I think that's right. We see a lot of promise, a lot of excitement for ways that we can use these tools to support remote patient monitoring, better management of chronic disease, provide more personalized treatment plans, engage patients in their care in new, important, different kinds of ways to keep them on the care plan. I hate the word compliance because I think it's a terrible framework, but to help patients really own and have the best possible success of staying on therapy for whatever disease. But what I'm seeing, at least in the US, is rapid adoption on the administrative side. So something like 40% of US practices are using AI tools today, but it's the completely unsexy stuff, right? It's dealing with prior authorization, administrative processes, scheduling, supply chain management, important aspects of the delivery system, but not things that I think most physicians get excited about, right? Not the things that allow us to actually make data-driven decisions at the point of care, like is starting to happen in some specialties, which you mentioned. Radiology has been, I think, at the forefront of a lot of the adoption of these tools, and we can talk about that in a little bit. I do think it'd be helpful, though, to make sure that our listeners, since this is the intro session, get some of the key definitions down. So, we hear all of these words. Could you just kind of walk us through, when you think about digital health components and some of these AI-specific terms, what are the buzzwords that people are hearing and what should they know about them?
Yeah. So right off the bat, digital health in itself is just the intersection, very simply, the intersection of health and technologies. It can be any sort of technology that you're using, and that it's a very broad umbrella. So then the components of digital health are, we've been hearing it, and most of our, physicians probably been using EHRs, electronic health records, for a while, which is essentially just the very simple fact of the patient's file in an electronic format, with the patient's history, medication, past medical history, the standard way we take notes on patients. I think, Jesse, what about, we hear the words telemedicine, telehealth. Are they interchangeable? Do you see, is there a difference in that? I think that also comes under the digital health umbrella as well.
Yeah, I think in general, when you have telemedicine versus telehealth, there's an important differentiation when you're talking about clinical care delivered by a healthcare professional versus things that are maybe a little bit broader, more consumer facing. And you see the same issue with mobile health applications that may be more consumer facing, but can also be used in conjunction with a healthcare practitioner, a physician, or other folks in the delivery system. And all these things, I think, get muddled really quickly. And that doesn't even bring us to those AI-specific terms that we're hearing all the time. Things like machine learning, deep learning, natural language processing, augmented intelligence. And I think it's helpful for people to understand that AI is sometimes actually kind of hard to define, but I like to say it's an umbrella term. There are different techniques and approaches that fall under the framework of AI, like machine learning, like deep learning, like natural language processing, like computer-aided diagnostics, and not get too worried about the specifics of any one particular approach, if that makes sense. I mean, does that resonate with you?
Yeah, absolutely. Because when we throw around the word AI now, I'm just taken back to the time when computer software, and some of the big companies that we know today had their name followed by computer technologies or software. And I think AI is eventually, now we're seeing AI labeled onto a lot of things, but eventually that's also going to be dropped out because it's going to be a core component in a lot of these things that are there. So I think when I think about AI, what I've come to understand is anything that is mimicking or trying to replicate some sort of human behavior, like adding reasoning or thinking behind that. But very interesting, and like we're going to talk about that towards the end of the seminar. And something that I know that you and especially the American Medical Association is very passionate about, and and all of us in the WMA also uses it, is augmented intelligence. Jesse, what do you mean by augmented intelligence? Because we've heard of artificial intelligence, but for us as physicians, I think augmented intelligence is a much better way of thinking about it.
Yeah, the whole concept of augmented intelligence as opposed to artificial intelligence
Yeah.
in healthcare is such an important point. And I think we are changing the conversation around this nomenclature. The idea is that we don't want to replace physicians. We don't want to replace healthcare team members. We want to boost their capabilities using these tools. We want to augment what is possible, expand the capacity of physicians and teams to do various things across workflows. And that's where that concept of augmenting comes into play. And that's why the AMA has really adopted this concept of AI in healthcare being more representative by the words augment intelligence rather than artificial intelligence. I do think it's helpful, though, for people to recognize that while there has been this huge inflection point, and we're seeing all sorts of really exciting things happen, and certainly, the emergence of ChatGPT a little over a year ago has gotten this into everybody's nomenclature.
Yeah.
AI in healthcare is not new. The concept of AI goes back to the 50s, and I'm curious if you want to give folks a little bit of a historical perspective of how expert systems have evolved to where we are today.
It's amazing because Alan Turing, some people consider him the father of artificial intelligence, came up with the seminal paper in the 1950s, and a lot of what he had described is actually now coming into actual practice and actual practicality. In the initial stages, there were simple problem-solving programs like Dendril, and then we started to see in the 1970s a couple of models called Internist 1, Mycin. Mycin was an expert system for antibiotics, but they still did not have the kind of output that what would really aid us and help us in our practice today. Rapid developments. Then there was this, people may hear this period of a winter, AI winter, where there wasn't much happening, but I believe in the background, a lot of the building blocks were being put in place, where then you started to have this boom. We saw, IBM's chess beating Gary Kasparov, and then there are so many other aspects, but people used to use those kind of terms to determine AI, whereas now the AI that we're looking at is much, much more different. And to the point where, like you mentioned about ChatGPT being one of the large language models that are built on, and so many other models that have been in the news. There's been a lot of other models that have just recently being mentioned. I was really impressed with another tool that is revolutionizing drug discovery, and that's DeepThink's AlphaFold. And so you're able to predict, drugs and medications because they're able to predict the protein molecules. So we're seeing this huge change in the last 75 years in terms of what was conceptually possible and now what is practically possible. And it's now applying directly into our clinical aspect. What do you see about the adoption, Jesse? Like now, do you feel in the next couple of years that we're going to have people who don't use AI, it's going to be in silos, or is it going to be something that it's going to be integrated into our computers as EHR and dictation systems already are?
I think we'll get to the point of integration. Today we have these sort of
Yeah.
one-off individual siloed systems that don't integrate. That's not sustainable. It's not scalable. It doesn't work. But if we're really going to get to a point where these things are integrated and there's widespread adoption, we're going to have to make sure that we emphasize and maintain safety and trust in these tools.
Yeah.
And we've got to put patient safety first. It's got to be a fundamental priority. We've got to have the right validation frameworks. And that is a really important, challenging question, I think, across the entire globe. In the US, the FDA does not know how we should best regulate these tools in a healthcare clinical context. And there's a lot of debate globally around what standards should we have in place for regulation and validation of these tools? What kind of accountability frameworks do we need to make sure that when I walk into an operating room and I turn on a ventilator and there's an AI algorithm trying to modulate my inflation pressures to optimize ventilation, that I know and can have confidence that the tool is actually going to work? And that doesn't even get into the really important issues around data protection and privacy and important considerations to make sure that patients have the confidence that their data isn't going to be misused as it's training algorithms or being fed into algorithms to enhance them and those kinds of things. So I think there's a lot of important work that needs to be done to ensure the safety and trust of healthcare in AI. Ultimately, we've got to make sure that there is physician oversight of these tools as an essential safeguard. And I think that's going to be the important driver of adoption globally at scale.
I think that it's really good that we put that right at the beginning of this session, because no matter what we discuss, whatever are the new things that are there in terms of what are coming up in terms of developments, having that core thing as patient safety, as a fundamental building block on all of our discussions going forward is very key. Because if we as a physician, if we're not using these tools and at some point there is some sort of harm that comes, and we know that in our incident reporting system we can see different ways of reporting, and if these tools come into that sort of factor, it's really scary to think about what will be the impact to our patients. And then at the same time, we have to think about who would be responsible because we've employed these tools. So you mentioned that oversight is there, and there's this term that that is in the vernacular within AI called human in the loop. I think that definitely applies to us in clinical practice in medicine, AI in medicine. Human in the loop is essential. Us as physicians, like you said, if it's trying to regulate flow or medication output or something, there needs to be at this stage a physician oversight, because we've been hearing about AI on a daily basis. It's in our headlines on a daily basis, and we tend to forget that it's a very new, in terms of the kind of capabilities that we're seeing now, it's relatively new, and it's not something that we as physicians should jump without making sure it's safe for our practice and for our patients.
So Jacob, I know people are talking a lot and have a lot of questions about generative AI and what it means for medical intelligence. So can you kind of just describe what is generative AI for all of our listeners today?
So I'm going to frame it in two ways. One very oversimplifying aspect is teaching them a system that you have multiple colors, and here it is able to draw something new that has never been drawn before. When it's applied into healthcare, it's about systems. So essentially systems creating new content on training data. So based on, say, 100,000 electronic health records, it's able to generate a new health record. We can also see generative AI generating images, CT scans that can be used to potentially train models as well. So that's kind of something that we're seeing a lot happening and a lot of models being deployed there. Anything you'd like to add on that, Jesse? It's a tool it's something that's been being said a lot about right now.
So is a large language model the same as generative AI? I think people might be confused about that.
So essentially, when you say an LLM or a large language model, is that if you can picture the entirety of your library, being put into a system. And what it does is, based on all of that information, it's able to predict the next word. So if I'm going to say a sentence, I would like to go to, based on everything that it says, it might fill in the next thing as in to the park. That's essentially what a large language model is. And so with that, it has taken, generative AI, I think, has taken it a step further to create things that are even beyond what we have in front of us, like pictures at the moment, records, documentation. Please add on, Jesse. Yeah.
Yeah, no, and there's this other concept that is important, because you hear companies, academic centers, other institutions, government talking about the creation or release of these new foundation models. Can you just maybe describe what a foundation model is, so that people hear that and they know what it is?
Yeah. So when we are looking at these models, these foundational models are trained on large, huge, vast data sets and adapted for a specific task. So large AI models adapted for a specific task. I think one of the key things in using these models, and especially you mentioned, Jesse, about large language models, especially right now, we hear this term called prompt engineering. So what do you feel physicians should be aware about? What is this prompt engineering, and how can they use better prompts, essentially?
So yeah, prompt engineering is basically crafting an input to get something out of one of these generative AI systems. And anybody who's used ChatGPT from OpenAI or Microsoft's Copilot or any of these large language model tools knows that, depending on the specific words, the phrases, negative language that you put into a prompt, you can get wildly different answers. And so there's kind of this interesting art that's developing around how do you write the right prompt to get the output of the system that you want. Let me just go back to this concept of a foundation model. So that people really get it. And I'll give an example outside of medicine, so that hopefully people can kind of connect the dots. So a foundation model it's a big model that can then be adapted for a very specific task. But that big model can be adapted to do many, many specific tasks. There are incredible models out there for image generation. Midjourney is one of the more popular ones. You can take this foundation model, and I can feed it 12 pictures of Jacob, and then it can be adapted to give me any picture I want of Jacob doing anything that I could possibly imagine through a prompt. Jacob surfing on a wave.
That's a bit scary, Jesse.
But that's what a foundation model's doing. And it is incredible to think that literally with 12 pictures of Jacob, a foundation model can be that sophisticated for the adaptation of that specific task. So you think about that in a healthcare context, and it's really incredible to think about where we can do with the ability to support all sorts of clinical opportunities, research applications, communication tasks, let alone medical education and training. I'm curious, I get asked all the time, well, what is this doing today for physicians? How are these tools helping? What are you seeing? I'm happy to share with what we're seeing in the US.
I think we're I think we've touched upon it, a number of use cases. I'm seeing a lot in radiology, like we said, in ophthalmology. And these are the reason I feel this is based on pictures, images where they have identified patterns, and we are able to identify patterns. And so for example, with radiology, with chest x-rays, you're seeing a lot of unlabeled chest x-rays and labeled chest x-rays. So the system in itself is able to understand, okay, these are the features of a pneumonia. These are the features of a potential consolidation, things like this, and putting it together and making suggested or high probability. So I saw an interesting use case happening where it would say that this is a high probability for a pneumonia, and it brings us to attention. So coming from an ED background where we have to review so many x-rays in a day, that kind of tool would really help us to kind of speed up the process, because as we know, we want to triage and help keep the patient flow as fast as possible. What about you, Jesse? Any other examples that you're seeing?
No, that radiology example is very relevant. There are more than 1,000 hospitals in the US that are using AI tools to support radiology workflows, right? And that can be a tool that the radiologist has that suggests a diagnosis. It can be a tool that can step in the middle of the night when a neuroradiologist is not available to read a head CT, but an emergency physician needs it immediately. And they need that support to know, is there an aneurysm that's ruptured or not? So I think there's a lot of excitement that's happening that is somewhat specially specific. But I'm also seeing a ton of work and a ton of uptake that's really aimed at reducing the administrative burden. And I think a place that's gotten very crowded in terms of tools in the market is an ambient dictation, right? So tools that just listen in the background to a conversation that I'm having with my patient and then generate the note. And who wants to sit there and type away at the end of the day all of their notes? Nobody, which is why these tools have exploded in their uptake because it reduces the burden of having to actually do that very laborious, labor-intensive task. And so, streamlining communication. There are a lot of healthcare systems in the US that when a patient sends a message, that message is being intercepted and addressed first by one of these tools. And if it's just a sort of pleasantry, like, happy birthday, Dr. Ehrenfeld, or, thank you so much for a great visit, these tools are automatically responding, and those messages are being filtered and never shown to the practitioner. Now, that can reduce the burden of getting through my day, and we know that, certain practices, certain types of physicians can get burdened with thousands and thousands and thousands of these messages. There are questions about, well, what does that do with my relationship to my patient if, I never know that Mrs. Jones sent me a lovely little message to say happy birthday because she happened to know. So I think there are a lot of things that are happening in these applications and these use cases where you see more and more, I think, diagnostic capabilities coming online as people start to understand how these things can get integrated into their workflows. The other thing that I think is really interesting is what's happening in the education space. And I'm curious if you have any perspective to share with our listeners about what you're seeing or what the potential opportunities are to support, workforce expansion and personalized education.
So I'll start with a negative first. When ChatGPT first came out,
Okay.
I saw right away a lot of people who are looking into publishing papers and doing research would put in and ask ChatGPT, help me to, write an article about prostate cancer from urology and something specific. And ChatGPT would output a very intelligent looking thing full of, references that look spot on. And then when you go to check them, they're all actually made up. And that's one of maybe just defined. That's where we see this term of hallucinating. The language model is hallucinating and making things up there. So I think
Jacob, and I will tell you, I just got to interrupt. I was on the receiving end of that as a journal editor. I edited an informatics journal, and I actually had somebody call me and they said, we have these references that ChatGPT gave us, but we can't find them. They're in your journal. I said, they're not real. They're hallucinations. They're made up. And this was early after ChatGPT had been released and people didn't understand what a hallucination was. So that is a real problem that's actually caught a lot of people off guard.
Yeah. And, when we're talking about, I think, moving into, you had mentioned about medical education, I think it's essential for medical students and colleges. I know you're an associate dean at a college, and I'd love to hear your perspective at that, as to, equip the medical students or the future doctors and increase their AI literacy without compromising on the core knowledge of what it means to be a doctor. How do you navigate that with your background?
Well, I think this is an opportunity to really hone in and personalize how we deliver education across the entire education spectrum, whether that's somebody who's in practice or somebody who's just at the beginning of their training. I'll give you an example of a tool that the AMA is helping to develop. The concept is like so simple, people will get it instantly. What this tool does is it looks to see, for patients that I'm going to see tomorrow or next week based on schedule and electronic health record, it scans all their records and looks for, the odd diagnosis that maybe I haven't seen a patient with this particular disease in a while, or someone who's on a new medication maybe that I might not be very familiar with. And then it serves that up to me in a little bite-sized format. And we were able to demonstrate that a 10-minute interaction with a tool like this that's giving very targeted, specific information that's relevant to me and my patients could actually change 2.5 clinical decisions. 10-minute tool making that much of an impact on the decisions that are happening in the care process. You back that all the way up to, early medical education, where, learners have different needs, they have different strengths. But in most education paradigms, everybody tracks along getting the same thing, taking the same exams, getting exposed to the same content. How we can actually personalize to the needs of the learner, where their strengths and weaknesses are across content areas, is, I think, where there's a really interesting and exciting opportunity to use AI tools to create personalized precision learning experiences that can help them really achieve competency, hopefully at a much, much faster level. Now, that's a big goal, and there's a lot of parts that have to come into practice to get that moving forward, but we so desperately need it. Because, when I talk with my counterparts in the WMA and across the world, everybody is driving 90 miles an hour into a workforce wall. We just don't have enough people. We need to expand our workforce. We need more physicians. We need to boost the capability of our physicians to have more capacity. And one way to do that is obviously on the training side.
But so, Jesse, as we're talking about boosting capacity, I think, the number one, on the flip side of it, the number one question that I get asked, especially when, taking part in talks or webinars or just talking to your random healthcare professional, the number one question I get asked is this going to replace me? At some point, is this, tool or solution with all that we're seeing, as I, as a doctor, will I no longer function? Is there going to be something else? Do I need to learn another profession? Should I switch over? And I think that's a very valid concern people are having, especially in these early stages. And this is where I feel the WMA's approach, and as you mentioned as well, the AMA's approach of calling it augmented intelligence, where it's going to be an aided tool that we use to become better doctors, but it's not going to replace us as doctors. And I think that's a very important point at this stage.
No, that is the crucial question. Will AI eventually replace physicians? And the answer is no. I like to refer to the WMA's very thoughtfully crafted statement on augmented intelligence, which really emphasizes the fact that the goal here should be to use AI to enhance, but not replace physician judgment. And we've got to make sure that these tools maintain and support our relationship with patients, not interfere with them. As I think about, the space that's out there, there's a lot of excitement. But what people need to remember is that AI is just making predictions. It's using data to make a prediction. That's what these tools do. But there's a space where we don't have enough data to make a firm prediction about a therapy, about a disease trajectory, about any kind of prognostic outcome. That's where judgment comes in. And there's always going to be a need and a place for judgment, which is something that humans will always have to do when prediction ends. So there's a place that AI can take you, and it can get you pretty far. But if you're solely relying on AI, you will hit a wall and not be able to actually benefit from the judgment that a trained human professional, a physician, can bring. And that's why this concept of augmented intelligence, I think, is so important. But that doesn't mean that people aren't worried about it. And I understand that. And I think we're seeing this happen across industries. There are lots of professionals out there who are worried about their jobs. I think the analogy in the legal profession that I heard at a conference once was, these AI tools are okay, and maybe they get to the level of a junior associate, but they can't replace a law partner, if that makes sense.
But so I think just in this period of like sort of an uncertainty, it's up to us as physicians, as to our colleagues, maybe institutions or associations. I know the AMA and many other associations do a lot of work educating and trying to equip our colleagues with this information. And I think this webinar is kind of is a core idea behind that, so that we can understand and start relaying this knowledge. And I believe it is so important for us as physicians to be part of health AI development tools, rather than us being brought in at the end as an advisor and say, okay, do you think this tool works? What do you think? Right at the beginning, at these inceptions, I'd encourage all of the people, all of our audience, physicians, healthcare professionals, get involved, look around what's happening, speak to the people, and be on those boards, be on those, at those C-level positions, trying to advocate, trying to implement. Because at the end of the day, I really do believe our experience and that we bring, being ones who have that direct patient relationship, that needs to translate, because that helps us to ensure that the system that are being created, the AI systems that are being created, are transparent, they're explainable, people can understand what's going on. We don't have this concept of a black box. That's another term people say. And the reason that this term black box is used is because people will be like, we just don't know what's going on. I mean, if you as a patient, or if my patient came to me and I made a decision and I'm not going to explain to them why I did it, it's a secret or something, they would not accept that. And I think it's important that we try to emulate what we practice into these AI systems, so that they become safe and they're efficient and deliver the outcomes we need.
I have to tell you a story, and I could not agree more. Physicians have got to be involved at the design, the development, the validation, the deployment, and the monitoring stage. It's critical. Otherwise, we get tools that don't work. And we live that experience in the US with having bad technology, bad usability thrust upon us that has just added to the burden of getting through your day. I once was at an AI conference, and a developer, very excited, came up to me after I gave a talk, and he said, Dr. Ehrenfeld, I've got this tool, and it can predict if your patients have colon cancer and need an operation. I said, okay, so that's kind of interesting. How does it work? Well, it's a black box. It's deep learning. We can't really tell you how the tool is making the decision. So I said, okay, hold on. I'm going to tell my mother that she needs her colon taken out by a surgeon because of your algorithm, but I can't tell her why. And you think she's going to accept that? What surgeon is going to act on that? And what third-party payer, insurance company, or government is going to pay for it? And so that experience just sometimes describes the disconnect that can happen between software developers that are doing things in a vacuum versus sophisticated organizations that have physician involvement throughout the AI development lifecycle, which is really, really, really important. You did mention this concept, though, that I think is really important. If there's one thing that people take away today, I'd like them to get this, which is transparency. So when you say transparency in AI, what do you mean by that? Because I think this is so important for our listeners to understand.
Very simply is that whatever, like you use that simple example, whatever is being decided or the output, I can connect the dots backwards to find the sources, the clinical validation, the research behind it, so that it is very clear that the output is related to things that are being built and being practiced. And that doesn't have that, that is not in a black box that no one knows about, but that is explainable. That's another term that we can explain, like we have to our patients, and we must do to our patients. And so they can understand it. And there's a clear connection from the beginning to the end to the output. And we can connect each of those dots and say that this is why this decision has come or this output has come.
Yeah, and that transparency is so important. We have seen examples in other industries where there's been a lack of transparency with catastrophic results. And so a really key example is what happened with the Boeing 737 MAX.
Yeah.
The 737 MAX had a catastrophic loss of 2 airliners. And that was because of an AI safety system that was built. And the AI safety system had a malfunction, with a sensor gone wrong that led to those planes crashing. The shocking thing about that whole episode is that the pilots had no idea this AI safety system existed.
Yeah.
It wasn't in the operations manuals. There was no training. They were just put in a plane that had a system that was doing something that they weren't able to control because they had no idea what was going on. We just can never allow that to occur in medicine. And that's why making sure that there's transparency. When I turn on a device, when I'm using my electronic health record, when there's a new tool brought into my operating room that's got AI built into it, I at least need to know that there's AI there, even if I can't always understand what it's doing. And many of our listeners, they may not want to understand exactly what the AI tool is doing, but they should always know that there's AI inside if it's used in a clinical workflow.
Jesse, you remind me of basically what you're saying. It reminds me of my early days when I just finished medical school, and one of my mentors, more than the clinical knowledge, he told me you need to advocate for your patients. You need to go that extra step. And I think that's the same principle we need to be applying here of this protecting this patient-physician relationship, advocating for them even in the development of these tools. So Jesse, I think we've received a few questions from before.
Yep.
We're going to have Ashok come back in, and I think he has some of those questions and some questions of his own as well.
Thank you, both of you. That is very interesting, a bit confusing, but there's a lot. There's a lot to really get your head around. And I think it's obvious that some things we can easily accept, like AI is doing pre-authorizations and routine stuff, routine administrative stuff. But even there, I mean, I think sometimes you get AIs talking to AIs, and without monitoring, you don't know what's going to happen. And they're talking increasingly fast, and feedback can be so fast. So where we all worry, I think, is when AIs make diagnosis or where they recommend treatments or investigations. So it was really a question of, if you are using an AI system and it makes these recommendations, are you obliged to follow them? Or if you don't follow them, are you liable in some way if something goes wrong? Or if you do follow them and something goes wrong, are you liable or is the AI liable? So Jesse, maybe I can ask you to.
Yeah, no, it's a really important question. And obviously legal frameworks differ. The ethical principles, I think, underlying it are the same. Ultimately, it's about ownership and accountability. And today, the standard of care has not changed. The standard of care, which of course is defined locally, someday will change. And someday the standard of care, I think, will be that physicians are using these tools to support diagnosis, to support practice. We're not there yet. In the meantime, there are companies that are saying, we will hold up our end of the bargain. And if something goes wrong and a tool is used and there's liability or harm, we will actually step in and address it. Not every company has taken that approach. Most companies, I think, don't want that because they say, well, look, it's just a suggestion. It's a tool that you can choose to use if you want or don't want. And if you look at the terms and conditions of a lot of the products that are out there, they make it very clear that ultimately the liability rests with the physician who's using the tool. So at the end of the day, what I tell my colleagues is you've got to use your clinical judgment. And of course, that can be guided. It can be supported by these tools in lots of different and interesting ways. But ultimately, you're the one who's responsible for the care of your patients. Jacob, I don't know if you have other thoughts on it.
No, you covered everything, Jesse, and it's very important what you mentioned, and I think that's important for all of our audience as well. Every tool that is out there, ChatGPT, OpenAI, Google's tools, all of them within their policy, their privacy, their terms and conditions, and their the fine print say this should not be a replacement for clinical practice or clinical knowledge. Do not rely on this information, even though they've been trained and they're outputting things. So that's a very cautionary word that you have given, which we need to apply.
In fact, if you look at OpenAI's terms and conditions for ChatGPT, it's explicit. It says, do not use this for healthcare decision making. And of course, We know that millions of people are. So there's obviously that disconnect between what the company says you should and shouldn't do with the tool and what people are actually doing.
True. I think, yeah, it's going to take some time for us to really lay down the borders, the parameters strictly. But I think one of the things that we can't get away from really is that we still have to follow these the basic principles, ethical practice, clear documentation, et cetera, et cetera. We can't change that just because AI is there. So, for how should clinicians approach documentation when they're using AI tools in their decision-making process? Do you say, this decision was made by such and such an AI, or how would you approach it? Jacob, would you like to field that first?
So I think Jesse touched upon that each of the individual institutions will have their documentation requirements, the broad countrywide and also international best practices. As of yet, I don't think we have international consensus on certain things, but it's important that countries start developing these kind of aspects. I was always taught document everything, put down everything. So if you have gotten something that's an input and you validate it, I would recommend putting it in. But I would defer also to let's ask, these questions. Push your hospital administrators and those in your chief of departments. Ask them, what do we do in these systems? And so we'll start to see. I mean, right now there is very fragmented policies coming in, and I'm hopeful that over time those fragmented policies will become more unified, and we'll see them like being in our medical practice and being taught at the medical education College of Medicine level as well.
I think the flip side too is what do we disclose to our patients? And I think there is no clarity on when do you need to tell a patient that you're using a tool for some particular part of the care process. I don't think it should be a blanket, every use of AI is disclosed to every patient, because I think that will be meaningless and overwhelming. So today, there are thousands and thousands and thousands of CT scans that are done using AI tools to reduce the dosage of radiation that people are exposed to by doing image planning. Do we disclose that to our patients? No. I think probably most patients couldn't care less that an AI tool helped, get a little more precise, view of whatever is being imaged to reduce the dose of radiation. But there are other circumstances where I think people would care very much that AI was used in a diagnostic process, and figuring out, when do we disclose things, what do we disclose, at what level, and then how's that all get documented, I think is an open question.
And we touched upon this earlier, and I think it's worth mentioning it again. At this stage, whatever information is being put into these tools, it's important to know where that information goes. Is it staying within the local areas, the local servers, or is that going back to the actual vendors? These kind of things are important to have an understanding, because we don't know what kind of information is being shared. Are they being, anonymized? Is information, the PHI, patient health information, taken away so that there's ways that can be done? Because right now, we know that, they say data is the new oil. Well, we don't want to be feeding or feeding without the permission of our patients, of course, when they're being providing their data, especially in these factors.
In fact, Jacob, you answered the question I was going to ask, which is basically about the data privacy, because these AI systems are trained on huge amounts of patient data, and even anonymized data can in some circumstances be de-anonymized by sufficiently advanced AI systems.
Yep.
So how should we move forward with data privacy protections? Should there be any changes, or can we just go on as we've been going on before?
I think it's important that our patients understand how their data is being used and have an opportunity to opt out if they don't want their data to be used to be training systems. It's important that we have the right consent processes for the usage of these tools, particularly if data is being used in ways that patients may be harmed by. Obviously, there is a lot of concern about data privacy, data security. You can't go a week without finding another cyber incident occurring somewhere in some healthcare facility. How do we make sure that we protect data appropriately is obviously a challenging space, and I don't think there's a clear answer to that.
Dr. Ashok, if I can put you on the spot before we move to the next session, as you had mentioned in the beginning, like as you were just still learning about AI, but as the WMA president, what do you feel it's important for us as physicians and the WMA membership, which I think is more than 14 million members as a whole, equipped when they think about artificial intelligence and their practice? Sorry to put you on the spot there.
No, because I think whenever we think of using AI in our practice, we have to remember that we have to put our patients first. So anything that you introduce to make your work easier, to help you diagnose better, everything has to be with the patient's best interest at heart.
Yeah.
And always, we have to follow the traditional things. That is, get the patient's consent, explain things to the patient, make sure that everything you do, you're standing in a fiduciary relationship with your patient. You have to make sure that their interests are put first. And so even though the tools are new, I think the principles, the ethics, the basics are as old as a profession itself. Yeah,
that's wonderful.
So, just one more question if we have a little bit of time. There's so many different tools. Just this last week, I was meeting with someone who has come up with a new tool. So it looks like every doctor, everywhere he goes, will meet someone who's got a new AI tool. So how do you select what's good, what's appropriate, what's useful for you?
It's a really important question, and there's so much out there. There's so much slick marketing of these different tools. I think the first question is, does it work? Does it work in my patients? Was it tested in my kind of population?
Yeah.
Doing something that's actually relevant. Another question is, what kind of regulatory approval was provided? Those regulatory frameworks are evolving, so that may not be as helpful today as hopefully it will be in the future. Another question is, what kind of validation studies were done, and were they in the peer-reviewed literature? There's also, a question about, does it integrate with my existing system? What is the challenge of actually getting these things up? And I will tell you, I talk with a lot of CMIOs who are very reluctant to bring in a technology from an unproven company, a startup, because they're not sure that that vendor is going to be there in 18 months or 3 years. If they go through a process of tool identification and validation and integration, and the startup's not around to support it, obviously that's problematic for that practice. So understanding the company that you are working with and its trajectory is also, I think, as important as the tool itself.
Yeah.
It's complicated.
Like Jesse was saying, I would stick, and then just to, just very simplified, the same way we make decisions on new medications, new kind of, those same principles, just because it's AI, don't stop applying. They are still there, the way we put our framework and our filtration as well.
Yes, that's true. And as you were saying, Jesse, different countries seem to have different levels of regulatory oversight here. I think many countries, especially the developing ones, it's like the Wild West. Anyone can come and sell anything, and because it does help. I mean, undoubtedly AIs do help, because it helps people who are in countries with less regulation may start using some questionable systems.
Yeah.
So that's the danger, I think. So if an AI system recommends a different sort of treatment approach than what I initially considered, and then I look at it and both treatment options are reasonably valid, then who's responsible? If I make the decision saying, I'll follow the AI, is the AI responsible then? Or am I responsible?
Jesse, I think you should take this, because the AMA has done a lot of work in terms of liability and explored this, and you
Yeah, I mean, our position is that the liability should be shared, which is consistent with how we think about medical device liability today. But that liability framework is not clear, and we don't have case law. We don't have enough experience to really understand how this is going to play out in the marketplace. And there have been attempts by some governments to pin all of the responsibility on the physician.
Yeah.
I don't think that's right. I think that, the developer, the implementer, the clinic or the system that bought the tool, in many cases probably does have some shared liability in the component. But we got to do what's in the best interests of our patients. And ultimately, humans have to be the final backstop to make sure that patient care is the best possible quality.
Yes, the basics can't be forgotten. And finally, I'd just like to ask you about the AI hallucinations. I mean, I've read a little bit about it, and it sounds frightening because it's so plausible. It seems really convincing, and then suddenly you realize it's just been conjured up out of I don't know where. So, how do we address this issue? I mean, is there any are there any tools for checking on it, for instance?
When it comes to hallucination, yeah, go ahead, Jesse. Yeah.
No, go ahead.
When it comes to hallucinations at this stage, I've seen the rapid change that has happened within the LLMs as well, the improvements that are there. But again, we came back to it, and I think one of the key takeaways is don't go away from your basics. So when you know what you're doing, when something is coming out and the output may not seem right, you have to always validate it. And even if it's written in such a way, because at the end of the day, let's not forget the LLM models are there to please and to make best for what people are doing. They're there to please the prompter. So the output is sometimes still going to be a bit funky. So we need to still look at it and we need to evaluate it. There are tools that are out there, but I'll have to be honest that you can check. Sometimes what I do is I would check multiple tools. If I get an output, I'll put it into other LLMs to check it, or into certain functions that do search, have the ability to search the web as well and give me sources. So it's looking at those kind of actors as well. Please, Jesse, anything you'd like to add?
Yeah, no, I think it's important for our listeners to just recognize that hallucinations are a part of the output of LLMs. They always will be. And buyer beware. You have to understand that, what you get out of a large language model may sound beautifully convincing, but it may be completely inaccurate and wrong.
And I think on that worrying note, we shall end this month's webinar. And I'd like to thank all the participants for taking the time out from your day to listen to this enlightening insight into a very new field, which I think we're all going to see more and more of. So Jesse, Jacob, thank you very much. Thank you to the WMA Secretariat, especially for arranging all the hard work behind the scenes you don't see, much like AI. So good work. Thank you.
Well, thank you, Ashok. And we really are excited for everybody to dial in today. We've covered a lot of ground, foundations of what do these things mean, how do generative AI and large language models have the potential to transform practice? How do we balance the human elements of healthcare with these emerging technologies, and what are some of the implications? Jacob, let me turn it to you to close us out and talk about what's next.
Yeah. So next month, as I mentioned, these are the beginning. This is the first of a series of webinars. So mark your calendars for February 27th. We'll be talking even more. We touched upon it a bit, but even more in detail about ethics, the legal and regulatory aspects of AI. It will be crucial as we navigate it. We're going to talk about frameworks, consideration, liability, regulatory requirements. Talk about privacy, data protection. So you'll receive registration details in the follow-up emails. In the chat, you would have also received a feedback form. We'd love to hear from you, hear about how this session went. What are your questions, further questions that you might have? What other sessions that you would like? So we encourage you to join us in the upcoming vital discussions as well.
And before we conclude, I do want to express our sincere gratitude to Dr. Ashok Philip, President of the World Medical Association, for your excellent moderation and insights in all that you do on behalf of physicians globally. Also, the WMA Medical Technology Working Group for organizing this education series. We have an incredible technical team behind the scenes that has made this a smooth experience, hopefully for everybody. And most importantly, everybody who dialed in and participated with the discussion. Jacob?
So as we mentioned, you'll be receiving a link. You got it in the chat. You'll also probably receive the recording, and we're going to send you a summary of these key points and resources discussed. I want to leave you with a quote from Alan Turing. He said this in his seminal paper: "We can only see a short distance ahead, but we can see plenty there that needs to be done." So we look forward to doing that. Thank you for joining us today, and we ask you all to join us next month. Have a great rest of the day. Take care.